What's the purposes of charting? To inform others of the care that you gave, justify charges for the services you provided, allow review for quality assurance, and to defend your care against a lawsuit. That's kind of, wouldn't you generally assume that to be the case? And we're not going to talk about physician order entry, which is another disaster. But talking about a waste, you know, you get the wrong person doing this, you get the wrong person. These people cannot. Here's my goal. I would like to have the doctor's brain be free-floating. No body, just the brain will just come into the room, be introduced by your scribe, and the brain will assess you and treat and examine you. There will be no computer touching, no charting, no pens, no nothing. You're just free-floating brain throughout the department. Here comes the brain will be talking to you now. Can you imagine how many patients you could see if you were unencumbered? But we're moving in the wrong direction. We're just going slower and slower and slower. So I'm going to make the point that charting is expensive because I said we saw 2.8 patients an hour. We generate $500. So charting costs $23.33 a minute. How out of an hour's time, if you're seeing 2.8 patients an hour, how much of your time is going to be spent charting? 15 minutes, 10 minutes, 12 minutes? It's going to be something substantial, right? So the idea here is that we have to get this down, and we have to focus on why are we doing this? Except for charge capture and coding purposes, most charting is never read. The family doctor doesn't care about what your history and physical looks like. They want to know what's the diagnosis, what tests did you do, and what treatment did you give. That's all they care about. That's all they care about. Lawsuits, they say, oh, you know, those of you from EMP are going to be going to this risk management course that Kevin's going to put on, and he's going to tell you you cannot chart enough. But the fact is that 99.99% of your time, charting for medical legal reasons is a waste because we only get 1 in 30,000 suits per year. So 99%, you know, 29,999 of those is a rehearsal. It doesn't matter because you're not going to get sued. In the last 10 years, our group has paid out $50,000, one claim where we paid money in 10 years. So all of this other defensive charting, you know, everyone pushes for this defensive charting, but it's really kind of a waste too. There are only two goals when you look at charting improvement: faster, better, faster, better. That's it, faster, better. When I say better, we're talking about, is it clinically better? You know, did it result in some better care for the patient, or were you able to get it done faster? Because, when you think of it and you look at everything that's being presented to you in terms of a charting option, it is all slower, and you cannot prove it's any better. It is all slower. So basically, this is what you're supposed to do. Unless you can unequivocally demonstrate that charting, the new charting way is faster or better, you shouldn't do it. You can't afford to do it. And especially those of you who are independent contractors, the physicians are independent contractors, going to go slower, see less patients. It's called making less money. That's going to happen to you. And so doctors are coming up with all of these workarounds to deal with some of the challenges that we have before us. But you need to resist this stuff. Now you can say, well, the horse is out of the barn, the engine's out of the station. There's no resisting this. This should be our goals, to unencumber providers and the staff at charting, nurses and doctors. We're doing too much. There's no other service business that spends 15 minutes out of every hour telling you what they did in the other 45 minutes. None, except we've gotten used to this. We want to generate records that are neat, legible, and meet charting requirements, Medicare, all that other stuff. We want to facilitate care so that throughput is improved. We want to allow subsequent providers to know the important parts of what we did. And we want to put, it sounds kind of interesting, point of service decision support. That's one of the buzzwords of electronic charting. So that when you have put something in there about an ankle, you pick out the ankle thing, and it tells you about the Ottawa ankle rules and the Ottawa knee rules, or the Wells rules for DVT or PE. You can't remember all that stuff. So the idea is that when you pick up the chart automatically will give you some of this decision support in terms of helping you through these cases. Here are unproven assumptions that you need a medical EMR, and the EMR facilitate healthcare in the industry, just like it did the airline and banking. This analogy just does not hold up. This is about one doctor or provider seeing one patient, trying to establish instant connection with that person so that they think that you care, and trying to find out what's wrong with them. And when we have the idea of doctors and nurses being data entry people at $23 a minute, it's a fundamental mistake to assume that this is a good thing to do. And those of you who have EMRs, where you're doing histories and physicals, not computer order entry. Computer order entry, a lot of people like that. You know why? Belly pain. Hit that one button, you just blew out $1,500 worth of tests. One button. No thinking. That's what we get paid for, by the way. No thinking, the belly pain workup. No thinking, the chest pain workup. Just went to the computer, put that, bam, done. Is that something to be admired? But in any case, we're talking about histories and physicals, something that is much, much more difficult to achieve. Can you show me that the EMR will improve care, that it will allow us to see more patients, that it will decrease errors? I have lots of papers in our database that says this isn't the case. I can show you a paper that says 22 ways that you can make a mistake with an electronic medical record. Doctors don't understand the benefits. So we're viewed as kind of, don't you get it, doctor? Why don't you stop resisting this? We see no benefit to it for ourselves. We see no benefit to our patients. And there are other ways to get the same data that I'm going to show you about. But administration knows best. Let them pick out the system, and computers are the answer. This is not what you should be seeking out. This is not. Doctors, the computer is bad. That's bad. It's bad. It's not what you should be seeking out. Unless you can clearly prove in a meaningful way that you've improved productivity, you're seeing more patients, or the quality of the care is better. Unless you can prove this, don't do it. This is what it's about. This is what it's about. There are all these papers now about what do patients think when you've got your back turned to them entering this data into this. You want to tell me a little bit more about that? Okay, hold on. You know, is that the experience you're trying to create? Doctors' work should be facilitated. We're now getting it encumbered. I don't want to spend a lot of time going through the pros and cons of each of these, because it's really, we don't really have the time. And you can read it, and a lot of it is self-evident, but computerized is at the top of the list because they talk about, well, you can readily access patient records. Well, we scan our records, and I can readily access any records I want from a scanned record. Facilitates capture of mandated charting elements. Yeah, it does. You know, it says, doctor, you only put down 18 review systems, and you need to have 25. So it can tell you that. Point-of-care decision support is a strong component of this. The idea that it can help you through the Wells rules and all of these other kind of things, I think is genuinely legitimate. And potentially the ability to populate new records from the old records. So now the patient comes back and all of the prior history is on and all that other stuff is added, and I think that there's some advantage to that. The cons, it costs a lot of money to get it, substantially slower than other systems. Now, I would ask you, those of you who do histories and physicals by electronic records, how many makes you go faster than what you had before? All right, let's count those hands. All right, how many makes it go slower than you went before? I rest my case. So these are the obvious ones. But I want to talk about Scribes, because anybody in the room use Scribes? Oh, 1, 2, 3, 4, 5. 5 of you. Okay. This is a revolutionary idea that you should embrace immediately. Scribes basically facilitate your documentation. They go ahead, they can ask them questions in advance of you coming there. There's certain parts they can't ask. They can assist you in doing these exams, they can chaperone them. And the question is, well, who owns the Scribes? Are they hired by the doctors, hired by the hospital? If they're hired by the hospital, they can chaperone the exams, and they can assist in the exams and hold the kid down and all those kinds of things. If they're hired by you, they probably ought not even touch a patient. The issue is who pays. All the doctors who have Scribes, basically, they pay the full freight of these Scribes. Anybody have the hospital pay for the Scribes? Well, the fact is that for every patient that you see, you generate $100 for yourself and $400 for the hospital. So you would think the hospital would pay 80% of the Scribe because they're going to make you go faster, more efficient, et cetera, et cetera. They get a disproportionate benefit out of your productivity. But does anybody? No, they don't do that. Most hospitals don't even know what a Scribe is. This is what you want. This is what you want. This is Dr. Roseborough, my friend, Dr. Wagner. That's Patrice. Patrice is an EMT. She's also, when she's working in our department, she can be a scribe or she can be a clerk. She knows everything. This lady's got like arms like an octopus in terms of her ability to do stuff. Here's Scribe Companies. They'll hire Scribes for you, train Scribes for you, pay Scribes for you, because you don't want to have Scribes in terms of screwing up your pension plans and all that other stuff. We'll do it for you. One of these companies, the largest one, I think is called Scribe America. It's $20 an hour. Now, getting a Scribe for $20 an hour, all these benefits here kind of thing, it's a bargain. It's a bargain. It's a very reasonable price, $20 an hour. Because you can see more patients, yes. We're the only place that has complaining of too much business. You know, you've got people in the waiting room waiting. Okay, if I bring them in, I can see them faster now. I'll get my charting. They know how to chart better than you do in terms of the charting elements and all that other stuff. So this is something to consider. And it's not just about basically going faster. It's also, there's a quality of life issue, because you have the physicians have a 25-year career being an emergency physician. This makes your life much easier. Like when Dr. Roseborough the scribe doesn't come in, that guy is sitting in the corner, sucking his thumb, rocking back and forth, saying, oh God, the scribe's not here today, kind of thing. Because his adrenal gland is like a little raisin, because he's been an ER doctor for a long time. And so this basically makes his life much better. Most ER groups are just not entrepreneurial at all. And I've seen individual physicians say, fine, the group doesn't want to do this. You hire your own scribe, and when you go to work, they show up. You've taught them. They're your buddy to get you through this. I knew a physician who did this in Colorado, because the group just didn't have the concept of this is a reasonable thing to do. This is ideal. In-department transcription, we had this for a ton of years. It's really cheap. Patient goes to the floor with a transcribed chart. It is very, very cool. I have no idea why in-department transcription, because the ideal chart is really a hybrid of a check-off and transcription. You can check off all of the family history, all that other crap. And most of the physical exam can be checked off, because the vast majority of a physical exam is normal. Then you can just talk about the abnormal parts, which is a small minority, and then you can do the medical decision-making, which really works best when you talk about it, and it has to be done kind of in little pieces. Talk to the family doctor, see the patient on Tuesday, their CAT scan came back, all of these things. If you don't do it as you go, then you have to do it at the end of the visit, which means that doctors are always staying over their shift to do the dictations, making up histories and physicals because they don't remember what they did an hour ago or 2 hours ago. So this is all basically a fabrication anyway. Or is this just me? So outsourced transcription, it's okay, but in-department is very cool. Anybody have in-department transcription? Why don't we do that? Why don't we do that? It is so cool, because this person who is there, when they're not transcribing charts, because they're not transcribing the entire chart, they're just transcribing the key parts of the chart that we think ought to be transcribed, they can do 3 charts an hour. When they're not doing that, they can do other things for the department. Voice recognition, yeah, this stuff's pretty cool. It works better and better. Charting templates, fast. Does medical staff love them? Yeah, right. What did you see here? How can I reconstruct this thing? Where is the flowery words and the words of intensity in that chart? And how do ankle sprain, big deal. Chest pain, big deal. How about grandma was tripped on the telephone cord, fell and hit her head and got a laceration, and then she was bitten by the pet cat? Find the template for that. So here's the Holy Grail, basically, a hybrid of checkoff and talking. That's the Holy Grail, I think. It does the best of both. I don't want to really talk about paper-based charting for nurses, because it's really analogous to the same thing for the doctors. But you're being dragged into this because the hospital says, well, we got this computer system. We now, close friend went to the emergency department here in where are we? Las Vegas, University Hospital, and had an ER visit, and was given a copy of their ER record when they left, computerized charting. It was 6 pages long, 2 columns. Detail, 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 all macro, macro, macro. It was all crap. 6 pages of crap. Perfectly timed. Whether it had anything to do when the service was rendered is another matter. So, I think that this is one point to take home that will save your hospital hundreds of thousands of dollars. Nurses should not capture charges. Guaranteed. We have done audits around the country. I'll show you the data. It's not a matter of how bad you're doing it, and not a matter of if you're doing it badly. It's just a matter of how bad. So you see these places where the nurse is doing the stickies and the checkoff chart and the fees here and the barcodes there, and it's bad. It's really bad in terms of what they lose. You think that your per diem nurses care one whit about your charging? What about the registry nurses? They really know a lot about your charting, right? Yeah. This is the only business where they allow the cashier to determine the levels, the price of bananas. This is 15, maybe so, hospitals that we did charge audits at. This is the error, this is the mistakes that they made. We did 3-hour hospitals in New Jersey. I don't want to name the system. They lost $100 a chart in charges, and this was like, probably 8 years ago. That 100 is probably now 400 now. This is what you need to capture data and charges. You need a Bob. You need a Bob. Every hospital needs a Bob. Bob is what you need. Bob will put down your charges. If the nurses put it down on the chart and document it, time in for the infusion, time out for the infusion, Bob will put it in the computer, not you. He'll get the charges. He'll determine the level of service based on your documentation and an algorithm that has been agreed upon by the hospital. The idea of nurses doing it, ridiculous. Bob, not only will he get the charges done and the levels of service done, he'll also put down key times. Every piece of data that I'm going to show you comes from Bob. Bob gets it for us. So I know every drug, every test, every supply by doctor, key times by doctor since 1993, because Bob did it. Everybody needs a Bob. He puts it in a computer database that we have, and that's cool. This is what he captures. He captures everything. I know the first and last set of every soul who've come into our hospital, first and last set of vitals on every soul since 1993. I know everything about everybody who's come in. So I have more data than you do, but we don't have a computer system. We have Bob. Bob, you need a Bob. We don't spend $8 million in having nurses and doctors doing data entry. Primitive. Bob is accurate. Bob's good. He consolidates. We have one guy who does all the charges for the hospital, everything, doctors. He also does ICD-9 CPT coding for the doctors as well. All of this stuff is so fragmented. You go to a hospital, the doctor's got ICD-9 CPT coding, the hospital's got ICD-9 CPT coding. They're going to get charge to capture for the doctors, level of service, different people. No way. It would really be cool if everybody had the balls to basically say, let's have one company do the billing for both groups. You get the same information, send out one bill. If you go to a hospital for an ankle sprain, you get a radiologist bill, a hospital bill, and a doctor bill. Now, where's the sense in that? This would be really cool if anybody had. Now, those of you who are doctors who have gone from the hospital doing your billing to the outside billing company, you'd never go back to the hospital. You'd never go back. But the hospital keeps on doing it. The hospital is maybe good at capturing small numbers of large charges. We're good at capturing large numbers of small charges. Scan the paper. We scan our records, and we then distribute these records electronically to the medical staff. So as soon as the patient is done, the record's scanned, key pages of it are sent to the family doctor. The family doctor has a copy of the record before the patient is even home that says, I'm going to see the patient tomorrow or the day after. Some hospitals, they take the illegible third NCR copy, put it in an envelope, put a stamp on it, send it to the doctor, arrives to the doctor's house office about the day after the patient left for their follow-up visit. So I think that we need to be much more aggressive about challenging who says this is the way to go. Where's the return on investment? Why are we doing this? There's so many opportunities here where we're just moving in the wrong direction.